Welcome to the Taylor Method for Pain-Free Living, a podcast that features enlightening conversations with experts in the medical field that helps to improve the health and well-being of those suffering from chronic pain due to injury. Learn from leading authorities the questions you should be asking to experience pain-free living. Hosted by father and son, Dr. Derek Taylor and Dr. Hudson Taylor, and joined by industry professionals in the health field, including doctors of integrative medicine and personal injury attorneys. Enjoy well-rounded and informative conversations to help you get out of pain while achieving optimal wellness. Dr. Derek Taylor and Dr. Hudson Taylor are the doctors of Taylor Chiropractic and Laser Center in Florida and California. Both father and son duo have earned respect and a solid reputation for successfully helping people transform their lives by assisting them to discover the hidden causes of their painful health challenges, leading them to experience the resolution of their problems using the Taylor Method. Tune in each week to learn about the Taylor Method, Dr. Taylor's proprietary technology that looks at the whole person and identifies the root cause of pain while facilitating natural healing and helps to restore the body to optimal wellness without using drug injections or surgery.
Okay, welcome to the show. This is Dr. Derek Taylor. I'm here with Dr. Hudson Taylor, and our guest today is Nick Haffey from Comprehensive Hand and Physical Therapy in Jupiter, Florida. Nick, welcome to the show.
Thanks, guys. Appreciate you having me. Good to see you.
Yeah, so we're excited to have you on the show here. Now, how long have you been a physical therapist for?
I find it hard to believe it when I tell people, to believe it myself, but 20 years now I've been a physical therapist.
Wow,
So
that's great.
I feel like I'm barely over 20 years old, but I guess that's not the truth.
Yeah. Well, now over the years, you've done a lot of different conditions that you treated, but you're on the show because we understand that you really love to focus on and specialize in shoulder conditions. Is that true?
That's correct. Yeah. So as you know, as physical therapists, we train in treating the entire body, but I would say, especially over the last 10 years, I've probably focused more of my clinical treatment on shoulder. I still do treat other general orthopedic conditions, but the physicians who I work closely with, they see a lot of shoulders. So I see a lot of non-operative and postoperative shoulders from my referring physicians.
Got it. So I would assume that you prefer to do you prefer to get a patient who's non-operative or postoperative?
Well, obviously, we like to try to see people non-operatively so that they can avoid shoulder surgery.
Why is that?
Well, so shoulder surgery, as many people that you speak to and in the community, they'll say, "Oh, that's a terrible surgery," and that can be the case. Typically, if somebody has to have some sort of surgical intervention for the shoulder, there's going to be a prolonged recovery. Usually for the first month or two after the surgery, they might actually feel a little worse than they did before the surgery, unfortunately. So if there's a way that we can help them to avoid the need for that surgery at all, it's ideal. But in some cases, there's just too much structural damage and people have to go in and have surgical intervention. And so obviously, I think the post-surgical patients are pretty fun as well, because you get to see a tremendous amount of progress. You take somebody who is in a sling and can't use their arm and take them all the way back to, recreational or competitive sports activities, or just recreational golf or tennis or what have you. So.
Mm-hmm. Okay. So you prefer to see them pre-operative or non-operative, and I would assume that a lot of these cases, you can help them prevent surgery altogether.
Yes, and that's the goal, and usually that's the goal of the surgeons I work with as well. They want patients to exhaust all measures of conservative care to really know too that the surgery is the only option for them at that point. So the other thing that even if we can't conservatively manage someone's shoulder issue, sometimes when I can see them preoperatively, it gives us a great idea of their baseline and their level of function going into surgery, so that we really have a reasonable expectation of what they might achieve after surgery as well. So so it's always, even if they end up having surgery, it's good to see them pre-operatively in order to try to avoid the surgery altogether, or at least to sort of get them prepared for the surgery, and maybe have a good understanding of what our expectations are after the surgery's done. So.
Yeah, I always tell that to our patients ourselves. I mean, they start on a course of care, and even if they end up getting surgery, the outcome of their recovery is going to be so much greater if we can clear out a lot of that scar tissue and get the shoulder functioning to as close to 100% as possible.
Yes.
If they say they do need surgery, their recovery time is going to be cut in half, just because we've already cleared out so much stuff in the shoulder and it's already so much better. Do you find that the case with yourself?
I 100% agree, and I have that same conversations with patients who are, because oftentimes patients will see something on an MRI and they'll know that they have pain in their shoulder and dysfunction, and so sometimes in their mind they think, I've got to have this thing fixed, I need to have a surgery. So sometimes they're a little hesitant to even go down the road of conservative care, where they might say, hey, I just want to get this thing fixed right now and get going. But oftentimes I'll say exactly what you've just mentioned, in that, if we can prepare them for surgery, because again, oftentimes we're working on a lot of soft tissue and joint mobility issues going into surgery. And it really cuts down on the amount of time that we have to spend doing that after surgery. So,
right. Yeah. Let's say they come in with the supraspinatus tear. Of course, those other muscles are going to have challenges and scar tissue in them in themselves. And so why not just work on, preparing that supraspinatus tear by clearing that out as much as possible, but then also knocking out a lot of the scar tissue and dysfunction in the surrounding muscles. And so that, when they recover, all they got to recover from is just that surgical intervention and the surgical procedure in of itself. And it's just going to be so much wiser, I think, and
sure.
a better way to go. Now, what are some of the common shoulder conditions that you see in your practice?
So we do see a lot of postoperative rotator cuff and labral repairs, sometimes less. So you mentioned supraspinatus. So that's the of the four rotator cuff muscles, the supraspinatus is the one that we're typically going to find that has some sort of pathology when the surgeons go in there. And most of the time, that's, if not the only muscle, it's definitely one of the muscles that needs to be fixed. So we see a lot of supraspinatus tears. And so now I do have a couple of labral tears, which, you manage them a little bit differently post-operatively than you do a rotator cuff repair. So it's important to know when we're working with these patients, really specifically what procedures were performed in the shoulder. And then there's other factors as well. You take into account individual factors of the patient, their age, their activity level, the demand they have for their shoulder. And then something that's important for us to know too is, the quality of the repair, the bone and tendon quality. And that's something we can really only get from the surgeon. So, and that might change the way that we advance somebody with the protocol. But oftentimes when I see somebody post-operatively, a majority of the time it's going to be a rotator cuff repair. Less frequently, we do see the labral and biceps tendon repairs as well. So.
Mm-hmm. So what is the difference in outcome that you've seen between, let's say, a rotator cuff tear versus a labral tear?
Well, so labral tears, I guess when you wake up from surgery, and if the physician tells you, the surgeon says that they found a labral tear in there and they had to repair it, as opposed to a rotator cuff, if it's not, you don't have both of those things, it's only one or the other. The labral tear is the, let's put up air quotes and say, easier of those two to recover from, because the labrum, as you know, is just a little cartilaginous extension off of the rim of the glenoid. So it's non-contractile, meaning that when a person moves or positions their arm, there's really no pull or force on the labrum. So we're actually usually allowed to take those people out of a sling and mobilize them and even start strengthening earlier on in the rehab process, as opposed to a rotator cuff tear. So now you're taking a tendon that attaches a muscle to the bone. And if you try to position your arm, even if you're trying to just lift up your arm to put on deodorant or something very simple like that, the rotator cuff, the rotator cuff as a unit, those muscles are going to contract. And so that's why we see these patients who come out of a rotator cuff repair and they're in a sling for 6 weeks. The surgeons don't want them to move their arm because they're trying to limit the amount of contractile force that's placed on that repair. So when somebody has that rotator cuff repair, it's going to be a little bit more of a prolonged recovery because of that period of immobilization. So the labral tears, when we get them, we can advance them a little more quickly and probably have an expectation that they might return to higher level activity sooner than somebody who has a rotator cuff repair.
But usually I would imagine that the surgeon is going to see a combination of the two, right?
You can see both.
Yeah, you can see that labral tear with some rotator cuff tear someplace, right?
Yes. If we see let's call it a more experienced shoulder and somebody who's maybe a little more experienced in life, if you will, because we don't want to say older, there might be more degenerative changes. So if you see somebody that has had a high demand of activity on their arm for many years, they played baseball in high school and college, or they were a volleyball player, some kind of an overhead or heavy use upper extremity athlete, that person might have a combination of some degenerative labral changes as well as degenerative rotator cuff tear, because not all rotator cuff tears have to happen with a single incident. I mean, I think that's a misconception that people have, is that a rotator cuff tear is something that happens at one particular moment. Sometimes there's more of a degenerative change over time in a tendon, because the tendons of the rotator cuff are fairly thin and avascular. So over time, if those tendons are being worn and frayed, they can eventually end up being torn. And so the tear might be more of a kind of a chronic, slow forming tear. So and those sometimes can be a little trickier to rehab than an acute fresh tear that's repaired pretty quickly.
So let's say one of our listeners is at home, they're struggling they have some shoulder pain and they don't know if it's a labral tear or if they don't know if it's a rotator cuff tear. They just know that they have this shoulder pain. What would you say to them as far as what are some differential diagnosis symptoms and signs that would differentiate the two between a tear versus the rotator cuff tear?
So that's a great question, and the shoulder is fun because it's a little tricky, right? So when we look at a shoulder, there are lots of things. I grabbed a shoulder model because I figured I would start talking about this, but when we look, so this is the anterior view of a shoulder with all the musculature removed. But oftentimes, if we just put our finger right here in this one area. So if I were to show you on my shoulder, a lot of times people will have pain kind of right up in this area of the shoulder. It may radiate down to the lateral arm. So if we're looking at this area of the shoulder, I mean, we've got a bursa that's here. We've got the rotator cuff tendons. We've got the long head of the biceps tendon, and we've got the AC joint. So there are a lot of different structures that are right here in this small area. So trying to determine which of those structures is the problem is very important. Oftentimes, if somebody's irritated their shoulder acutely or because of overuse, there's an inflammatory process that occurs with that. And as you know, inflammation can affect all the local tissue. So, the person might have an inflamed biceps tendon as well as a supraspinatus tendon and a little bit of bursitis to go along with it. So when I get somebody in the clinic, our job is to figure out which of those structures might be causing their pain and how are we going to address that. Oftentimes, as you probably experienced this in your practice, both of you guys, it's trying to convince a patient to stop doing what's aggravating their problem, which is sometimes difficult, because the first thing we want to try to do is settle the inflammatory process down, let the inflammation subside, because oftentimes if everything's inflamed and irritated, it's very difficult to determine exactly what someone's problem is. Now, once we get some inflammation under control and we take a patient through a physical exam, we try to differentially diagnose what tissue we think is in lesion there. So some of the things we're looking for, is does the patient have full active motion? And so when I'm doing a physical therapy assessment, that's, we take a thorough history and try to figure out how this happened, how it started. But we like to assess their active range of motion, their passive range of motion, and then the strength of different muscles in that region. Usually by the time we've taken a thorough physical exam and a thorough history of the patient, we can be reasonably certain that we know what's going on in his shoulder, and then progress our rehab from there. So one of the things, and some of your listeners might experience this, and I've seen it many times over the years, where their shoulder becomes painful fairly acutely, and it hurts to raise their arm, sometimes to the point where they can't raise their arm over their head. And so in their mind, they think, oh my gosh, it hurts I can't raise my arm, it's painful, I've torn something in there. Sometimes that's just not the case. Sometimes it's just that a tissue in that shoulder is so inflamed and painful that our body wants to inhibit our muscles from doing any further damage. So when we go to raise our arm and we get a lot of pain, the body's going to inhibit our muscle function so that we can't raise that arm. So that's why it's important to not necessarily make your judgment too early on with an acute type injury, and try to give that body the body some time to go through the inflammatory process, and then start figuring it out once you can test the patient a little more thoroughly.
So Nick, once you have a good idea of what's going on with that patient, how do you address a rotator cuff tear or a torn labrum in your practice, and what's your method for that, and how do you progress them? Let's say pre-op, before they get surgery, or if they don't want to get surgery, what's your method for that?
So with the rotator cuff, it's important to explain to, I feel like it's always important to educate our patients on the job of the rotator cuff. So simply, I explain to them that the rotator cuff is a group of 4 muscles together. Usually not all 4 of those muscles are torn. It's usually just one, or maybe the involvement of a second muscle, if it's a pretty significant issue. But I try to explain to patient that the job of the rotator cuff, those 4 muscles, is to maintain the congruency of that ball and socket configuration of the joint, as our bigger muscles like the deltoid, the pectoralis major, and the latissimus, as those muscles are moving our limb around through space. The 4 rotator cuff muscles, their job is to kind of maintain the congruency of that ball and socket. And oftentimes, when there's a disruption in that because of a tear in the rotator cuff muscle, we start to get inflammation because the joint doesn't work the right way mechanically. So when a patient comes in and they've been told they have a rotator cuff tear, I try to explain to them that what we're going to do is work on all parts of the rotator cuff that are not torn. So there's still going to be probably 3.5 muscles that are not torn. And we're going to try to make those muscles do the job of the rotator cuff. So oftentimes, if we can still create a situation in the shoulder where the function of the rotator cuff is quote unquote normal, the shoulder can then function without pain. So to answer your question, what we end up doing in physical therapy is that we target and strengthen those muscles of the rotator cuff that are intact, and then we try to make sure that they are like healthy and active enough to do the whole job of the rotator cuff, even if the supraspinatus is partially torn, or even if it's fully torn. Sometimes we'll still try to attempt that. And so the benefit of that is that if we go through all that strengthening, and we talked about this earlier, we go through all that strengthening, but the tear is just so significant that the shoulder just can't regain its normal function. Well, the patient ends up having to have surgery. Unfortunately, they repair that torn part of the rotator cuff, but then when we get the patient postoperatively, well, guess what? The 3 of those 4 muscles that we were working like heck before are in much better shape, and they're kind of ready to go once you once you get the person out of the sling and you start strengthening again. You don't have to spend as much time trying to build all those muscles back up post-surgically.
Wow. So the key really is to focus on strengthening all the parts that are still attached, that are not torn, just to allow the body to adapt to that and to overcome the other torn section. And when that happens, what's the success rate, with people? Do a lot of them avoid surgery? Will they still get surgery? But even if they do, like you said, they'll be in much better condition. But
Sure.
will it also ever reach the point where patients are like, hey, I'm feeling good. I'm not even really thinking about surgery.
Definitely. And that's always a big victory for us and for the patient. Is when you can take them through that process. And here they were faced with maybe having a surgery where they were going to be immobilized for 6 weeks, so that's a month and a half, and then even for the next 6 weeks, so for a good 3 months, like, they're not really going to have great use of their arm if they have this procedure, and we can avoid that. So I would say that of the patients that come in with shoulder pain, a majority of them do not convert to the need for surgery. And oftentimes, that's a function of the physician, the surgeon that they've seen. If the surgeon evaluates the patient and if they feel like there's a very decent chance that they can, conservatively manage the problem, they'll of course then send them to physical therapy. So they've already sort of been pre-screened, if you will, if they've seen the orthopedic surgeon and the orthopedic surgeon says, hey, I think this is not an operative condition, let's send you to therapy. But then even when we get, say, someone from a primary care physician or another healthcare provider that says, hey, go try some physical therapy for your shoulder, even most of those don't convert to, they do not end up converting to surgery. So it really is a last resort effort. Patients will ask me, hey, the MRI shows that I have a torn rotator cuff. That's never going to, is that ever going to heal? And the answer is probably no. And then they say, well, if that's never going to heal, then shouldn't I just go ahead and have the surgery? And the answer to that is still no. I mean, if the person has full range of motion in their arm, and when we do some strength testing of their arm and they can produce reasonable force with their shoulder, it means at least some of that tendon is intact. The MRI might be, and you guys, I'm sure, have seen this in your practice, like, the MRIs aren't always 100% accurate, so there could be like a little bit of a false positive or maybe a little bit of an overread by the MRI. So we don't want to use that as our trigger to do surgery alone. You got to do the clinical examination and you got to try the conservative care. So
have you ever seen, Nick,
sorry. Go ahead.
One last question. Have you ever seen full thickness, rotator cuff tears, get rehabbed and completely avoiding surgery? Yeah.
So those are difficult. When you, and honestly, so I think of a case that I had, this was probably a couple of years ago, of a male in his 50s who was very active, so very strong, had always used his shoulder for pretty high demand activities, both with his occupation and recreationally. So when he came into the clinic, he could raise his arm over his head. He could compensate very well with his deltoid and his other rotator cuff muscles. But if he would try to provide resistance, when we were to test the supraspinatus, he had no strength there. And this was also confirmed by MRI that he had a full thickness tear. He was somebody who did end up having surgery because even though he could compensate well enough and use his bigger muscles to still use his arm, it kept creating pain for him over and over because his shoulder mechanics, because the rotator cuff, what of the rotator cuff was intact, could not do the job that the rotator cuff needed to do. He kept having pain in the shoulder. So he finally did end up having surgery. So oftentimes if somebody has a full thickness tear on MRI, and when you test them in the clinic, they cannot produce force against your resistance in the directions that test the rotator cuff. If it's a person that's younger and more active, they're probably a surgical candidate. Now, if it's a person who's, let's say, 70 years old or older and maybe doesn't have a real high demand for their shoulder, that's when you're, the debate about whether or not somebody like that should elect a rotator cuff surgery gets a little more intense.
Because when you're older, I mean, it is an invasive procedure, and it's like, if you're older and you're not living a super forceful, active life, why undergo an invasive procedure that could potentially have negative consequences?
And Nick, do you find that we find this a lot in our practice, that patients go in with this idea that, man, they're just going to get the surgery and it's going to fix all their problems and they're going to be back to, in a matter of 6 weeks, they're going to be out and running again and doing all the things that they love. I mean, can you speak to that a little bit? Because you have a lot more experience with seeing all these post-op patients than we do. And this is your bread and butter here, right? I mean, people are coming to you after surgery. And so tell us, can you speak to the patients in regards to that? Because a lot of them we found in our practice have no clue. I'm sure you even have a lot more experience with that. Can you speak to that?
So we do. So there's, so as you have this, sort of this spectrum of patients that come into your office in terms of their personality and their attitudes and expectations. So on the one hand, you might have a patient that has had the fear of God put into them about using their arm after surgery. And so they're very anxious and they almost won't use their arm. And then on the other hand, you have these people that come into you post-operatively where, just as you said, they think they just took their car to the shop and had it fixed so they can go out and drag race now. And so one of the things that we have to do post-operatively that I find with some patients more than others is really explain to them the nature of the procedure that they had done. And then also explain to them the rationale for the protocols that exist following rotator cuff surgery. So surgeons sometimes have variations in their protocols, but so we use protocols as sort of a guideline, right? So generally speaking, the first 6 weeks after a rotator cuff surgery, if a surgeon has to put anchors into the bone and then pass sutures through a tendon and bring that tendon back down to the bone, that first 6 weeks post-operatively is crucial. And your primary goal in the first 6 weeks is to not screw up the repair. When I first came out of PT school 20 years ago, we used to treat rotator cuffs a little more aggressively because they would have this surgery and say, we got to get their arm moving right away so the shoulder doesn't get stiff and they don't lose range of motion. But unfortunately, historically, with rotator cuff repairs, there were pretty high failure rates. And so over time, it's one of the things that I've seen, where our profession has evolved a little bit and changed what we do with rotator cuffs postoperatively, and that we're now much more conservative. So oftentimes patients are, and of course, like the larger the tear, the more difficult the repair, the less quality that exists in the bone and the tissue, the more conservative the surgeon's going to be. So oftentimes you might have somebody, that, if they're a little bit older, it was a degenerative tear that's been there for a long time. The tissue quality might not have been excellent, in terms of like the tendon that the surgeon can get the sutures into and pull back down to the bone. It might not have been great. So those are all factors that affect that. So when you have that, you might have somebody that the doctor really wants, they might want them in that sling for 6 weeks doing nothing because they don't want to take the chance of disrupting that repair. So patients don't always necessarily, to address your question, like patients don't always necessarily understand that going into the surgeon. I mean, the surgeon does their work in a short amount of time, like in a given period of time. The patient has to do a tremendous amount of work after the surgery. And sometimes that work is just exercising patience, to try to avoid using the arm. I mean, I've even had some patients where one of the decisions to not do surgery comes because the patient, let's say it's a patient that uses a walker for ambulation, and they live alone. That's a patient who can't have their arm in a sling for 6 weeks, so that they won't be able to do what's necessary post-surgically to make that surgery a success. And so the option might be to say, well, let's just manage it conservatively and do the best we can. So yeah, it's very difficult sometimes to try to navigate patients through that post-operative period. Some patients, and this varies. I mean, I get patients that come in that are 6 weeks out of surgery and have almost no pain whatsoever. I get some patients that come in 6 weeks out of surgery, and this could be from the same surgeon that uses the same technique and does the same procedure. that person comes in and they have a tremendous amount of pain in their shoulder and they don't want to move their arm. I don't worry about them as much. I actually worry about the patient that doesn't have a lot of pain, right? Because that patient, in their mind, that patient thinks, oh my gosh, my shoulder feels good. I can start using it. It's fixed. I can start using it again. But we have to really explain to them that the protocols exist based on the time that it takes biologically and physiologically for tissue to heal. That's what we're waiting on. That first 6 weeks period is a waiting period to say, let's wait until if we, the surgeon has done an excellent job of putting that tendon back down on the bone where it originally attached. Now we're waiting for tissue to develop there. And so we don't want to do things that, that contract that muscle to try to pull on that attachment site to disrupt that process. And so for my patients that come in that are feeling pretty good and or maybe they just have a high pain tolerance and they think no pain, no gain, that's a difficult patient to manage because they're the ones that might end up doing something they shouldn't.
Well, what would you say to a patient then that says, well, if that's the case, then why even, I'm not going to get physical therapy for the first 6 weeks. I'm just going to let the scar tissue form over that and not do anything. What would you say to that patient?
That patient could be absolutely right. Sometimes in our business models, we love that, in physical therapy, I mean, since I've started, every prescription from a physician used to say 3 times a week for 4 weeks. And it didn't matter what the condition was. It was just sort of like the rubber stamp of prescription for physical therapy. A lot of times what I do with my patients in that first 6 weeks, if I see them for their first postoperative visit, which is generally around the 6 week mark, and there can be exceptions to that, but say it's like a pretty, it's a good repair. The surgeon's not concerned about the patient being too stiff, and they have them come see me at 6 weeks postoperative. If that patient comes in and so we don't assess active range of motion or strength at that point because it's contraindicated for the repair. What we do assess is passive range of motion, and typically the surgeons have given them like a little, like kind of a light home exercise program. So we'll assess their compliance with their home exercise program. We'll look at the shoulder girdle and make sure that they can still move their shoulder and move their fingers and elbow and everything else. If they come in and they've got good range of motion on day one and they're 6 weeks post-op, I've got patients in here right now that I only see once a week. I've got patients that I see, and if they start a little bit early, I might see them once only every 2 weeks. And the only reason I see them is one, to assess their compliance with their home program and answer any questions they have, and 2, to make sure that they're not becoming stiff. So if I see them on day one for physical therapy somewhere around the 6 week mark, and they've got really good mobility and range of motion, I don't need to see them. I don't need that person to come in 3 times a week and have me move them through range of motion that they already have. You know what I mean? I can just give them a home program and read them read them the riot act about not doing too much with their arm. Sometimes I have people come in, I just want to see them once a week so I can remind them not to do anything. I definitely have a couple patients that, when I have that patient that just doesn't really seem to kind of grasp the concept of not using the arm and adhering to the protocol, I like to make sure that I document for my own purposes and their purposes that I'm telling them over and over, you still can't use your arm. You're not really supposed to be doing anything with your arm. But yeah, you're right. I mean, you're absolutely right. There's sometimes is not a need to see somebody frequently in that first phase of recovery for rotator cuff repair.
What percentage of patients do you see that are still in pain after a surgery?
I would say it's more than half, because again, it's a trauma to the body. Oftentimes when somebody does have a rotator cuff repair, the surgeon will go in and they'll look at the shoulder and they'll address any issue that they see. And a lot of times you guys have probably seen these, people that have had subacromial decompressions. The surgeon will say, hey, there was bone spurs in the shoulder, and they kind of smooth out those. It's really the underside of the acromion that the surgeon is addressing, and that leaves patients a little achy. So oftentimes people have varying degrees of pain. It's very uncommon to see somebody that has relatively little to no pain. I would say that's maybe only like 1 out of every 15 or 20 post-operative patients that you see that just comes in and is like, yeah, my shoulder doesn't really hurt at all. So, and that's why people oftentimes say that, the rotator cuff surgery has sort of this reputation for being a terrible surgery. And I think it's probably because of that, because some people can experience a lot of post-operative pain.
So let's talk to those that are not having in a position where they need shoulder surgery or they're having shoulder pain. What are like your 3 favorite exercises that you like to do for shoulders that you use for preventative measures or for rehab? Just your basic common, maybe there's more than 3, but what are your favorite exercises that you can pass on to our listeners to help prevent a shoulder problem from happening altogether?
Sure. So one exercise that I tell people is sort of the quintessential rotator cuff exercise would be external rotation of the shoulder against resistance. And so that exercise it targets the rotator cuff, more specifically the supraspinatus and infraspinatus muscles for strengthening. And if it's an exercise that you can perform, then you're strengthening those muscles. If you find that it's an exercise that you continually have difficulty with, or maybe you fatigue very easily, or the patient feels like they're weak in that exercise, that could mean that they might have some pathology of the rotator cuff. So that's a pretty simple exercise. I'll just see if I can demonstrate for you, but you guys have probably seen this, and that's an exercise where we have the patient with their arm by their side, and we've got say we've got a resistance band that's coming in this direction. I'm in my clinic, so sorry, I've actually got a band right here, so I'll grab it. So that's an exercise where we got this band anchored over here, and we've got the arm by the side, and the patient's just rotating the arm out in this direction. So this is what we call external rotation of the shoulder, and it's a great exercise because it targets those rotator cuff muscles. And the keys with this exercise are that the patient has to keep their elbow flexed at 90 degrees, because what we'll see, sometimes we have cheaters, and the cheaters are the people that do this, they kind of stretch the band by extending their elbow. But really what they should be doing is isolating this rotation of the arm. I try to use an analogy for someone that's like, if somebody has a bunch of stolen watches that they're trying to show you in their trench coat, they're just kind of opening the one flap of the trench coat. Hopefully all of our listeners aren't criminals, but but that would be the motion that you're trying to achieve with that exercise. And so we typically have them start out with 3 sets of 10 to 15 repetitions, and they just kind of take that through a pain-free range of motion. So that right there, if you ever see somebody doing that exercise, they probably know what the rotator cuff is, because otherwise nobody would ever do an exercise like that. But for your patients who maybe have not addressed a shoulder, they have a shoulder issue, it's a great exercise to test your shoulder, but also to strengthen that rotator cuff. Another one, and this may be a favorite of you guys as well, like we just love a row. Just anytime somebody can do that, do a row where I'll show you this way. So they, now the band's out in front and they're just pulling back and squeezing the shoulder blades. Great for many reasons. It works the posterior shoulder, but it also helps kind of some of that forward posture that we see with a lot of our patients. You're strengthening those muscles on the back of the shoulder blade to kind of pull those shoulders back, because posture can influence the function of the shoulder. And oftentimes when we see these patients that have shoulder impingement, one of the things we see is they're kind of round shouldered, and they sometimes have a little bit of protraction of the shoulder. So that row, that scapular row, is actually another great exercise that I would say we probably don't have any shoulder patients that are not doing those 2 exercises unless it's just contraindicated for the time that they are post-operative. So
great.
Those are my 2 favorites. Those are the ones, those are the ones that, like I said, I probably don't have a single shoulder patient that's not doing those 2 exercises.
Yeah. Well, great. Well, hey, this has been a fascinating show, Nick. We appreciate you taking time out of your busy schedule to talk with us about these issues. And how can our listeners get a hold of you if they want to call you and reach out to you at your office, or you have a website or a phone number, or
Sure. Yeah. So all of the above. We're located in Jupiter, Florida, and we're right off of Indiantown Road. Our phone number is 561-575-4770. We have a long name. So our website is comprehensivehandandpt.com. That has some of our intake forms and things like that people can fill out. So my email is just my first and last name, NICKHAFFEY @hotmail.com. And of course, as promised, Dr. Taylor, I'll bring you some of my cards so that we can work directly with some of your patients that might need our help as well.
Yeah, great. All right. Well, hey, you've been listening to the Taylor Method for Pain-Free Living. Our guest today has been Nick Haffey. And thanks, Nick, for, again, your time. And if you've been dealing with shoulder issues or you're postoperative, Nick is the man to go to. And again, thanks for your expertise and sharing your knowledge with us today. It's been a pleasure.
Thanks, Nick.
Of course, anytime. Thanks, Dr. Taylor.
Take care. Good to meet you.
Thank you for listening to the Taylor Method for Pain-Free Living podcast. For more information about the Taylor Method and how you can find lasting pain relief, visit www.drderektaylor.com. That's www.drderektaylor.com.